Yeah. I thought that you had some great examples of how data can be used to inform health decisions. I guess, and showing how we could even link these various databases. What work do you do to satisfy yourself that the databases themselves contain truth before you begin to match the databases?
Well,
is the data valid?
Define truth.
Well, I shouldn't have said that. How do you satisfy yourself that the databases contain data that you'd be comfortable and consider to be valid?
Well, maybe I would pose it differently. I think I would start with a research question and a need for information. So, for example, I mean, colorectal cancer, there was a need. Then I would look at what information is available and see if I can put them together. And I would have to evaluate the quality of that database. I mean, I think it's a general question that doesn't apply to rectal leakage. It applies to everything in general. And you should always be skeptical about the information that is from a database. But I don't really have an answer to your question. No?
It's a loaded question in the sense that, for example, we know in the last year that the CIHI procedures database with the plex weightings has produced some real challenges. We've had to abolish the plex weighting.
Specifically for Ontario?
Yes, I sit on the data quality committee for the Ontario Case Costing Project and was absolutely delighted to see that you were using our data and scared silly to think you were using it. So I'm curious from the standpoint of a user how you think about that, or is that an issue? You sort of validate a data set because it's
well,
available.
It's always an issue that any data set you should always ask yourself questions, and normally you will do basic descriptive statistics to make sure that there's face value to what is contained in the database. I mean, it's like a normal process that you would go through. So when we did, for example, I said that we did a chart review of the Ottawa Cancer Centre to collect information about staging and disease progression. Well, the first thing we did is we compare with, there was a study in Manitoba in 1990, so not the same reference here, that did about the similar stuff. So we compare our result in terms of the staging distribution. Then we compare these results with the SEER data in the US. So how do we, I mean, we have to do validation. We cannot just blindly use data and process them. You have to validate their quality. We validate with face value of the information we know, and with comparing with other sources for which there is pieces of information which is the same. Neither the Manitoba nor the SEER data contain all the information we wanted about the progression, because in a complete simulation model for colorectal cancer, we want information from initial diagnosis to local recurrence to distant recurrence by stage. But still, SEER data has overall survival. We could compare with SEER. So it's by comparing that with other data sources and that making sure that there is validity.
That's helpful and comforting, because it sounds like you are thinking seriously about validating or wrestling with that issue before you move forward with some of the interesting findings you're able to find.
Yeah, and like when we look at the Ontario Case Costing Project, we did compare how they fit with the, at the time, the CNGs from CIHI data, such that we got relative...
And I don't mean to imply that that data set's not valuable. It just has so many holes in it in places that you'd probably be interested to see being filled in.
Yeah, but I agree with you. A model is wrong. The data is always wrong. But you should make sure before you use them that you validate, cross-validate them. That's what we're doing for all the pieces that we have used.
Thank you.
Other comments or questions?
And maybe just a little comment. I think in terms of when we collect information, this is a priority from the start. And you should make sure that there's quality control, evaluation, and monitoring of the quality throughout the collection of the process. When you put data together, you normally are not at that stage. You are an end user. So you should try to backtrack and find out what they have done, and you should do your own validation.
Thank you for the beautiful demonstration of the problems you can get into with linkage. And I guess sort of a comment is that I think it really lends to what is the question you're trying to ask. Because if you're looking at large population changes, then probably those kinds of linkage issues that you're looking at are probably okay. Whereas if you were looking at specific medical questions, you have to be a lot tighter. And so it really defines, that's the first or the best example I've seen of people demonstrating the issues with linkage. So thank you for that.
But what you mean for, even for specific clinical data, the work that Jack too has been doing, and he has done more since then, is quite specific in terms of the clinical aspect.
It depends on whether, I guess the usage is whether it is a broad population medical change or question versus, say, the equivalent of clinical trial workups for individual medical decisions that I think you have to be maybe a bit more careful of. And so I guess it depends on what the application is, the extent to which you can allow error.
I mean, you were talking about the error rate.
Yes.
Yeah. Well,
Yes. Yeah, but that's
I think,
demonstrated.
but I think that may depend on the type of study you're doing.
Yeah.
I know we're planning currently a study at Statistics Canada, which is the Healthcare Outcome Measurement Project, where we want to interview people who are scheduled for a specific type of procedure. Now we're looking at knee and hip, sorry to mix the two, replacement. And we want to survey people before the surgery, survey them 3 or 6 months after the surgery, but also request their permission to link with their healthcare records, such that we will get follow-up visit to doctors, and if there is readmission resulting from the surgery, we will get these complications. So I think it depends really what you want to do, but you have to be careful about the quality of the data. But in that case, we will ask them their health numbers, and we'll probably have a very good match rate.
Questions? Maybe I'll add one in. It's sort of a naive question of distinguishing between the roles of Statistics Canada and what you're doing, and Canada Health, the Canadian Information Agency, CIHI.
Well, it's a very good question. I'm not sure I have a very good answer, but I'll try one. I guess the Canadian Institute of Health Information mainly focus on providing information that is helpful to managers of the healthcare system. Okay, so hospital discharge abstract with complexity code, such that they can compare their performance. That's one example. Having a joint registry to help people understanding how many joints are replaced. So it's more the management of the healthcare system. Statistics Canada, I guess, would cover a broader aspect of health and would be monitoring more the health of the population. There is an overlap, because how many people go to the hospital is also related to health and healthcare management. But I think that's a distinction I would make between the two. So health information for the management system, health information for monitoring and informing for the health of the Canadian population.
Other comments or questions? Anybody else want to? Got such a star-studded audience here, but well, if not, I want to thank you for your presentation. We have a small token of our appreciation for your talk, and that George gave us good advice in inviting you here, and we're glad you're able to attend. Some have seen this before, but you've never seen it before.
Yeah, they've probably seen it
you will be
every
quite,
month.
Yeah, you'll be quite surprised. I don't have the slide that goes with it here today, but this is absolutely guaranteed to get your comments in your office, since no one will figure it. We claim it represents an excellent model of the health system and how it works. So you see on the back the description of the artist and the drawing, and thank you very much for being here.
Thank you very much.
And I just wanted to make one comment before we move on. The next talk, as Shirley mentioned, is by Horace Creever. I worked with him, had the honor to do that back in the 1970s when he ran the Royal Commission on the privacy and confidentiality of health records. He's now retired. He was a justice of I think it was the appellate court, and I don't know which other court in Canada. He's had an incredible life in the courts. He's a brilliant man, and he also is a very human person that has seen the evolution of privacy from when it was a computer-created, wasn't a computer-created issue or a computer-related issue, but was simply an issue of paper systems and people gaining access. And it went through an evolution where it became an issue. That 35 years that transpired between those two times has frustrated all of us. And I think you'll hear from Horace some of the different views he has over time, as he's given talks about every 10 years on that topic since he first did the commission. So we're welcoming him here. We're very pleased to have him here. And I think you'll enjoy his presentation. I'd ask you to let others know that the presentation will be on. And according to the registration, we may have a different location, but I think we'll be able to fit people in here. Anyway, Jean-Marie, thank you very much for your presentation.
Thank you.
Good day.